And I see we have Memphis, Tennessee on the line as well. Hello from Belgium. Very good. So it's 2 minutes after, and the doorbell is not ringing quite as much. So why don't we get started? And all of our speakers are here. I am Executive Director Peter Doherty. Greetings to you all, and I'd like to thank you for joining us today. This is the Society's first Distinguished Lecture of the year, and the primary purpose of this series is to encourage young professionals globally to pursue all of the possibilities available to them through this profession by offering inspiring talks from accomplished lecturers in the field. And before I introduce today's guest presenter, we are privileged to have with us as moderator, International Biometric Society Education Committee Chair, Rafael, and I'm sorry if I'm not saying your name correctly, Rafael de Andrade Moral, who will help facilitate the Q&A portion of today's session. And we appreciate the Education Committee's diligent work in identifying exceptional speakers for this series, and also for offering ongoing support to the project. Rafael, thanks very much for joining us, and we will hear from you a bit later. I'll also mention that this is the first of a number of educational sessions being offered this month. On February 11th, we'll be hosting one of 2 Florence Nightingale Awards sessions, with 4 of our Nightingale finalists offering their talks. And on February 21st, we will be hosting our next IBS Journal Club session, and we will discuss the recently published biometrics article, Distributed Model Building and Recursive Integration for Big Spatial Data. So we hope you'll join us. Registration details can be found on the IBS website. And remember that all of these sessions are free to members of the Society. There's more coming later in February and also in March, and all sessions will be offered to members free of charge. So just keep that in mind. And now on to today's session. By the way, we encourage participants to post their questions using the Q&A feature in Zoom. And we're also happy to answer additional questions following the presentation in the IBS members community once the session has ended, if time runs out. I'm happy to share a little bit about today's speaker, Sherri Rose, PhD. She is a professor of health policy and director of the Health Policy Data Science Lab at Stanford University. Her research is centered on developing and integrating innovative statistical machine learning approaches to improve human health and health equity. And within health policy, Dr. Rose works on ethical algorithms in healthcare, risk adjustment, chronic kidney disease, and health program evaluation. Her honors include the NIH Director's Pioneer Award, NIH Director's New Innovator Award, and the Mortimer Spiegelman Award, which recognizes the statistician under age 40 who has made the most significant contributions to public health statistics. And in 2024, she was recognized with both the Ashi Khan Willard G. Manning Memorial Award for Best Research in Health Econometrics and the American Statistical Association's Outstanding Statistical Application Award. So it is my pleasure and the Society's to hand the program over to Dr. Rose. Sherri, please.
Thank you so much for the invitation and the wonderful introduction. I'm going to share my screen with my slides here. And all right, so I'm delighted to be talking to you today about ethical AI being more than just loss functions. And as statisticians, we often think in terms of objective functions, but I want to start us in this talk by orienting on the state of algorithms in health, including the overwhelming hype cycle around large language models we are currently in. Then I'll discuss the need for standards for machine learning work, particularly in healthcare and public health. And lastly, the third section will focus on the social impact of algorithms and the many different ways we can think about that. So when we think about health algorithms, we know that there are many new algorithms in healthcare, and some have the promise to improve health and health equity. but many will not. And I put forth that our default assumption should be that they will not. And just because an algorithm exists or a tool exists doesn't mean that it will necessarily help with a health problem. And I will talk more about why this is my default assumption as we continue in the presentation. I also want to mention that when I talk about algorithms, I'm considering algorithms very broadly. So we can think about algorithms as being defined as a rule that takes data as an input and returns summary outputs. So we know that health algorithms are pervasive, particularly in health and public health and health policy, and that the data that we use has gotten increasingly complex. We often have information from a variety of different sources, including lab tests and measured health conditions, imaging. And then the algorithms that we use to analyze this data can range from a simple checklist in the emergency room to understand whether you should admit a patient, or standard regression techniques that are used to predict length of stay in the hospital. And then lastly, we have more complex algorithms that might be used to detect health conditions using images. But a key thing that we are thinking about with our analyses is that we want to have clinically or policy relevant results to inform decision making. But we also know that with the pervasiveness of health algorithms, which has only grown over the last couple of years in particular, that these algorithms can have a negative impact. And oftentimes that negative impact is felt most by marginalized groups. And there are many different groups that are marginalized by the healthcare system. That includes individuals who are from minoritized racial and ethnic groups, disabled individuals, people living in rural communities, those who are in a lower socioeconomic status, and individuals who are uninsured. These groups already have lower life expectancy and poor health outcomes. Algorithms could more frequently be contributing to improving health equity rather than harming it. So I noted that I would talk about the current hype cycle with large language models and generative AI in general. As statisticians, we know that these methods are not wholly new, although there have been a number of advances recently. But we've been doing so-called generative modeling for years and decades in statistics as well. I have three papers that I'm including on this slide. I don't agree with everything in each of these papers, but I thought they were a great place to start. Folks often ask me when they want to learn more from a statistical perspective or from a healthcare perspective, where should they be reading to learn more about some of the key considerations for generative AI? And I think these are three good places to start. And so if you're interested in learning more about the need for more rigorous evaluation of these tools. Most of them are completely inadequately tested. These are some good sources, as well as calling attention to other issues like maintaining privacy and security, equity considerations, and the lack of transparency in a lot of these tools. But some key takeaways to think about with generative AI in the healthcare space is to keep in mind that it has been repeatedly shown that these tools are not ready for diagnosis. So regardless of the headlines that you may see, digging deeper and digging into the papers and some of the many limitations of these papers, these tools are not ready for diagnosis. They may be suited for other things that are less flashy, like information retrieval, but not for diagnosis. Another key consideration that's highlighted in the second paper on this slide is that only 5% of the studies that they looked at using large language models used real patient data. Only 5%. So a lot of these studies are not conducted in realistic scenarios. And so there's been some examples when I talk about diagnosis where the study really looks at these structured case studies. It's not this iterative back and forth the way that it would be in a clinical environment, and these tools do not work in those iterative environments. Additionally, fairness and bias are rarely assessed, and we really need to focus on designing for integration into realistic use cases, because most of the use cases in the health space are not realistic. Additionally, I wanted to briefly discuss some of the implications of generative AI that are not necessarily about the technical considerations, but about the broader impacts for our society, including the environmental impact. The data centers that are being built to expand the capabilities of generative AI require just a large volume of raw materials to create, and they have a lot of electronic waste. the water to build these facilities is tremendous, as well as then the water needed to cool the components when these tools are actually being used. And then lastly, the energy use is substantial. And I know that many of you are familiar with some of these issues because they keep being discussed in the popular press. And I have a few articles on here that have discussed some of these things recently. But, for example, there's been studies that show using something like ChatGPT as a search engine takes 10 times more energy than using an actual search engine. And so we need to think about these when we have issues like water shortages around the world, where 2/3 of the world's population has a water shortage at least 1 month out of the year. Is this something that we should be using our water sources for? Secondly, I wanted to highlight the considerations around labor exploitation in order to use these tools. For example, we have folks that are making only $1 or $2 an hour on Mechanical Turk in order to do data labeling. And then lastly, something that we have heard a lot about this week, in particular with this, a lot of the news out of DeepSeek, but copyrighted material is used as training data. So artists creating art, those of us who write research articles that are copyrighted or books that are copyrighted, this material is used without consent. And this is a major consideration in the tools and what types of training data that they're using. And when it used to be such a big issue for us to post a free access version of our journal article on our website, that was a problem. The publishers would not like us to do that, but now it's suddenly all right for these companies to use all of this material as training data. So to close out this introduction, I wanted to make sure to center in this talk that we want to be focusing on justice when we consider algorithms. And what does that mean here? So we want to think about benefits, risks, costs, and resources being equitably distributed. And this is really important because, as I said, over the last couple of years, these tools have been the uptake on these tools has been really significant. And typically in the health system, there's a lot of conservativeness about changing how things are done. But the uptake of Gen AI tools has been surprising given how little they have been rigorously evaluated. In the US, we have Epic selling generative AI tools in their electronic health records products, including transcribing patient visits and drafting messages for clinicians. And this is already, again, before we've had comprehensive evaluations. And the goal here, the idea here is that maybe some of these tools would be saving time, but the studies so far are very mixed, and many of them show that these tools do not save time. So we have now all of this AI slop in our healthcare system, in addition to in all of our commercial products that we use in other aspects of our life. So with that, I'm now going to pivot to the second area that I wanted to talk about is standards for health algorithms. We know that they're pervasive and that they can cause harm, but how do we combat this? And where are we with minimum standards in healthcare? And the short version is there's a lot of work to do. But before we start talking about those standards, I think it's helpful for us to think about our data. And as statisticians, we think about data a lot. We don't have data on the world as it should or could be under a more just equilibrium. The world that we have includes societal bias, but we don't even have data on the world as it is. We have data with non-representative sampling, with measurement error. So we have the world according to data, and this can be especially problematic when errors are greater for different groups. And so when we think about data for ethical AI, we need to consider that societal bias can enter data in many different ways. Detecting bias can be hard. And throughout this talk, I will illustrate some of the constraints and constructs that are embedded within our data. So with knowing that the data we have are imperfect in a variety of ways, we also know that various guidelines have been proposed. This is just a few recent examples. This is not exhaustive. We have guidelines for randomized trials and diagnostic accuracy studies. A little over a year ago, the FDA in the United States also released final guidance on clinical decision support algorithms that they would be evaluating, but without an enforcement mechanism. And so that's something I'm going to come back to quite a few times, is that suggestions and requirements are very different and they have different outcomes. My own work is represented in some of these collaborative papers. And as I said, these are some recent examples, but uptake has been fairly weak on having established standards. So some of these guidelines are required when you submit papers to certain journals, but they are not pervasive. Another thing is that a lot of guidelines have historically been weak on ethics for algorithms. This is highlighted in the Gachoy et al. Paper, and it's something that we discussed in the Tripod AI statement led by Gary Collins. So when we think about ethics in other arenas, so for conflict of interest reporting, we think about ethics. With IRB reviews for studies, we have to think about ethics, but we don't do this for the impact of algorithms. And so we do it elsewhere. Why don't we do it with algorithms? That is one of the things that I think we should be considering more frequently. And in one of those papers, we discussed this ethical pipeline for machine learning and AI, starting all the way from problem selection through post-deployment considerations to center ethics as part of this process. And there's a lot of attention given on algorithm development, but there's other things that we need to focus on, including specifically what topics are funded, how teams are constructed. We know that with data collection and outcome definition, we often work with a lot of non-representative convenience samples. And what does that mean for outcomes that are differentially mismeasured? And with that, I want to give just one prior example of the impact of actual requirements on the robustness of research and how requirements are crucial for including increasing the rigor of our studies. So this is a plot of null results of trials from NHLBI in the United States for their clinical trials from 1970 to 2012. In 2000, you'll see this vertical line in the graph. In 2000, it was required to start registering primary outcomes on a website called clinicaltrials.gov. So prior to this requirement for registering primary outcomes, 57% of their trials demonstrated an intervention benefit. After this requirement, it was 8%. So it went from 57 to 8%. And there are many other examples like this. This is just one. So why do we have this need for minimum requirements? I would like to stress that there is incredibly high volume of low quality health, ML, and AI work in the published literature, not to mention other outlets that are not even peer reviewed. There are many issues in these papers, including a lack of external samples, a lack of multiple metrics. And I'll say that I used to talk about a few more technical issues on this, whatever version of this second bullet point that I was using in my slides over the last many years. But I took some of them out because over the last year or two, it's just gotten so much worse that I had to add clear description of tools. It's gotten to the point with the low quality of this work that it's really hard to even understand what the authors did in a lot of cases. And so a clear description of the tools in the manuscript itself, let alone additional more detailed information in an appendix. And certainly, of course, many papers don't have code. But it's the lack of this clear description of tools is really concerning, and how the bar seems to be getting even lower. And there's also continues to not be an emphasis on algorithmic bias and fairness or ethics. So what's the path forward? We need standards that are adopted by the community and followed by buy-in from journals and grantors. This is something that we know makes a difference, that suggestions do not lead to change. It does not lead to improved rigor, robustness, or fairness. And I mentioned that some of the guidelines have been adopted by specific journals. There's also been other areas of progress that I wanted to highlight. This progress can be slow, but these were important steps that occurred over the last year. So I was very pleased to see the BMJ last year in March now has mandatory data and code sharing for research published in their journal. This is one of the top clinical journals in the world. And this is the first time that I had seen a top clinical journal requiring data and code sharing for clinical trials, and then for other types of studies where you can't share data, they still require code. And I thought this was an important advance. So this is still not complete auditability for somebody who would want to audit the work, but this is a major step forward because a lot of the applied health journals do not have these standards. It has become very common in statistics journals, for example, to require data in code, or at least code if you cannot share your data, and then including simulated data with that code. But very pleased to see this. Another recent advance happened in December with the removal of the 12-month embargo period here in the United States at the National Institutes of Health for NIH-funded work. So previously, this work would often be embargoed for a whole year. So this would reduce transparency for people trying to access this research. So everybody should have access to this federally funded work to read these papers. But an additional challenge is that because of the increase in costs with publishing, there's many folks who used to have access, many researchers who used to even have access to journals no longer have this access. And so not only should everybody be able to access the NIH-funded work, even researchers specifically in the areas working on these topics were having trouble accessing these papers. So transparency is very helpful in tandem with other practices and policies when thinking about improving rigor and robustness. What are other implications of minimum standards? I think they are enormous. So we can have improved generalizability and transportability of the tools that we develop. Right now, there's so many studies where you can read them and recognize very quickly that it's unlikely that this would generalize or transport to another population because the work is at best, a pilot study. It would also lead to attenuated claims regarding readiness for translation and practice. There are many papers that make extremely broad claims about how ready their tool is to be used in practice without anything close to a rigorous evaluation. And additionally, the work would then contribute more frequently to improving health equity. Another major consequence that I believe would also happen, that I would like to see happen, is a decrease in so-called least publishable units. So publishing these very short papers that really didn't necessarily need to be a paper on their own. So short papers can be rigorous, but least publishable units are not. And we need fewer weak papers that effectively add nothing to advancing public health and health policy and science and functionally only serve to advance people's careers. And so higher standards can reduce waste. When we think about publishing less work and doing more rigorous work, we will save time, we will save resources, and this will happen throughout the research enterprise. And I think we can also all, when we think about having higher standards, we can all look at our own selves individually. I know that when I look back at papers that I wrote 10 years ago, there's some papers that I wrote 10 years ago that I either wouldn't write or I would write differently to be more in line with these more rigorous standards. Typically, when I talk about these topics, someone will invariably mention incentives. And so I think it's worth discussing incentives because we have to understand what they are in order to make change. And one of those is to understand who has power in these systems. So institutions have a lot of power to make change. So this can be universities or research organizations, journals, and grant agencies. I mentioned before, when journals uptake these new requirements and these policies, when granting agencies uptake these new requirements and policies, researchers will do them. And it's important to push for these types of changes, these global changes that can take longer, but can have a major impact. There's also the role of individual actions that when we think about who has power, some of us have more or less power within the systems that we are situated in. So for example, at my career stage, I have more power than folks who are early career. And so I can use that power. I can use my political capital in different ways to, when I'm writing promotion letters, when I'm writing award letters, to really advocate and highlight people who are focused on doing highly rigorous work, who are focused on building ethics into their analyses. But this is a question that I get constantly from early career researchers, is that they want to be doing things that enhance the rigor of their work, but that means that their work takes more time. And so for those of us who are a little bit further ahead of them, we can really create a space where they're being supported and they know that they have advocates for that type of work. And this all has to work together in conjunction with the systems. And so when we talk about individual actions, another thing that I think about a lot and that I talk about with folks is value alignment. And there are a lot of different metrics and ways to evaluate research. And it's important to ask yourself, why is this goal or metric valuable, and do you value it? We get a lot of messaging about what's important, and sometimes you can decide that something is not important and that you are not going to optimize towards it. And you can maximize your own optimization function. And with that, we can think about embedding your values locally while participating where you feel you can have an impact globally. And so these are just some thoughts about that, creating culture and environment locally with global versus local solutions. So one of those things is creating a lab manual where you focus on describing the different ways that you bring rigor to your work and the different ways that you bring your values to your work. And so, for example, in our lab manual, which I have a link to here, it focuses on a lot of the activities that we do for rigor and reproducibility, and also against the culture of overwork that is really predominant in a lot of research cultures. I also think that there's a lot we can do individually and locally to focus on timely and impactful work versus trendy and unrigorous work. So we do want to be timely, but we have to do that rigorously. And instead of chasing whatever the trendy topic is now and trying to get a paper out quickly, that's going to be unrigorous. And so that's the framing that I think about in my own work. We can also have a big impact on how we construct teams, and then other things like reproducible documents, code review, and code sharing. These are all things that we can build into our local environment in different ways. So with that, I'm going to move on to the social impact of algorithms section, where we'll be talking about a number of different ongoing and completed research projects where we're looking at these types of problems. So let's say we've done an incredibly rigorous evaluation of a particular tool. Even the most rigorous evaluations of algorithms still leave questions about the social impact of those algorithms. And when we are considering social impact, we can think about that as changes that aim to address injustice. And statistics does not typically link estimation problems with a downstream decision. That's not often how we write down our research questions. We're often writing down a loss function and thinking in terms of those types of statistical trade-offs. But another adjacent field, decision science, does explicitly always link a downstream decision to how they think about problems. Therefore, a lot of our work, our recent work and ongoing work, has been integrating these two fields and bringing a lot of the techniques together in order to try and look at the social impact of algorithms. This type of work goes against the motto of move fast and break things here in Silicon Valley. And social impact work must consider the underlying systems that algorithms will influence. And so that's something that we've been doing, considering short and long-term consequences. And our ongoing new work is developing a causal network model for understanding the social impact of algorithms before they're deployed, to try and anticipate and avoid downstream consequences, rather than deploying an algorithm and then waiting to see what happens and realizing that it's having a lot of negative consequences. Because then a lot of those consequences have already happened, particularly again for the groups most marginalized by the healthcare system. So to give an example of some of this work, we have new work that we'll be sharing in the coming weeks in a preprint of a new decisional analytic framework for health outcomes influenced by both social factors and disease processes. So historically, a lot of these frameworks have considered only disease natural history and not factored in these social factors or other things that we're bringing together in this framework. And this work has been led by PhD student Marika Cusick at Stanford, and is done in collaboration with two of my decision science colleagues, Fernando Alera Escudero and Jeremy Goldhaber-Fiebert. Another thing that we factor into our social impact framework is sources of knowledge and centering patient perspectives. And we understand that patients are experts in their own health conditions as well. So one of these projects, led by PhD student Agata Foricharj, is trying to understand social factors at the health system level and as well as outside the health system level. And we've been doing this in a series of focus groups this past fall, where we had 4 different focus groups of chronic kidney disease patients. And then earlier this month, we had a workshop with chronic kidney disease patients, an all-day workshop where they built a causal model collaboratively with us to bring these factors together. And we're looking forward to sharing that work later in this year. So when we study the social impact of algorithms, there are many different types of algorithms we can consider. And much of our recent work and ongoing work has focused on 2 areas. I mentioned chronic kidney disease just a moment ago, which I'll be talking about more in a few minutes. But another area that we've been conducting a lot of work is in planned payment risk adjustment. And for those of you who are not familiar with this research area, I have just a brief background slide to orient us on this topic. So planned payment risk adjustment systems are used in a number of different health systems around the world, including in the United States, aiming to redistribute funds based on health and encourage competition among insurers based on efficiency and quality, rather than them avoiding high-cost enrollees. And this has massive financial implications for the healthcare system. If we think about in the US, an average patient might cost around $6,000 a year. With over 50 million people in the United States enrolled in an insurance program that uses risk adjustment, in the US alone, this is hundreds of billions of dollars. And so when we look at this formula, we recognize this as a pretty straightforward regression where we have a spending outcome, a coefficient vector, and an input vector. And this input vector is typically many binary flags for different health conditions. It may also include in some risk adjustment systems, it may include categorizations for different groups based on documented sex and age. But one of the things that I want to highlight here about this being a regression is that the massive size of the healthcare sector makes risk adjustment arguably one of the most consequential applications of regression for social policy. And then to orient us on what a typical research question looks like in algorithmic fairness, we often have an outcome Y, like I just mentioned, where that in risk adjustment, that is a spending outcome. We have a vector X that includes a sensitive attribute A, which I haven't noted before. So building on that equation, we would also be thinking about a particular sensitive attribute or multiple sensitive attributes, which I'll talk about in a moment. But the typical research question only focuses on one, which is not necessarily realistic in health settings. But the goal in a lot of algorithmic fairness work is to create an estimator for the function of X equals Y while ensuring that the function is fair for A. Now, with that framing, one of the things we want to think about is the status quo of insurance algorithms. And some insurer uses of algorithms may be ethically unacceptable. So there's been a lot of research focusing on some of these topics, including coverage denials. And we wrote an article about this last year in March with my colleague, Michelle Mello, who's faculty in the School of Law here and also in health policy. But one of the things that I felt strongly about highlighting is that doing away with all insurer-related algorithms can actually decrease equity, particularly when we think about algorithms for risk adjustment. Because taking away risk adjustment algorithms would undermine equity because risk adjusting payments diminishes insurers' incentives to avoid sicker enrollees. When we consider in that regression the fact that the enrollee has a number of health conditions, that helps discourage the insurers from avoiding that enrollee. And there's different ways that they can discriminate against enrollees in the healthcare system. A lot of times this discrimination would be based on the different types of health conditions that they have. And for example, one of those might be mental health and substance use disorder, because mental health conditions are very costly. They are number 1 in total cost and number 2 in spending growth. And another thing in one of our research papers from a few years ago in biometrics we studied is that it was known that mental health and substance use disorders was an undercompensated condition in the risk adjustment system. So this means that the enrollee costs more than they get back, the insurer gets back. And so one of the things that we focused on here was creating new algorithms. And we focused on constrained and penalized regressions here that build fairness constraints directly into the optimization problem. And the choice of tools here was important because we wanted to focus on something that was very similar to what is already being used. I had other work where we focused on more complex machine learning and AI algorithms, but constraints and penalties built into regression is something that is much easier to understand and is easier to translate for policymakers and other stakeholders. And so what we found in this paper was that we could reduce the amount of undercompensation, so reduce the incentive for insurers to discriminate pretty substantially. Your standard ordinary least squares was undercompensated for groups that had mental health and substance use disorders by nearly $2,000. And we were able to reduce that undercompensation to very close to $0, to this negative $46. And so that negative $1,872 was 16% of mean spending. This was pretty substantial undercompensation. But one of the other things that we've considered in some of our additional work was that, as I signposted earlier, there isn't just one so-called sensitive attribute or marginalized group in the healthcare system, and there are multiple groups. And we built on this work and looked at fairness constraints for multiple groups, including 4 chronic conditions. So cancer, diabetes, heart disease, and mental health conditions, as well as building in some other techniques we had worked on in previous papers, including approaches for variable selection, to bring a lot of these techniques together. But one of the things that we were particularly interested in understanding is that there are a lot of subjective decisions to be made about which groups would be considered for inclusion in the loss function for a constraint or a penalty. And we focused on those 4 groups, but what was going to happen to other known undercompensated groups? And so on this slide, we have 17 of those known undercompensated groups. And what we found was that by improving fairness for the 4 groups included in the loss function, fairness was improved for 88% of these other groups. So the thing that we were concerned about was that improving fairness for some groups would harm fairness for others, at least among the groups that we were able to study. That was not broadly true. Where the money was getting moved around from was people who were overcompensated. So folks who had no health conditions were overcompensated by about $2,200, and that went down to around $800. So the money was coming for where we wanted it to be. We wanted overcompensated folks to be less overcompensated and undercompensated groups to be less undercompensated. But I did just mention one thing, is that known groups and subjective decisions. So in the last risk adjustment paper that I wanted to highlight, we were thinking about more complex groups and the fact that there are a lot of subjective decisions about what groups would be considered for any type of fairness consideration, whether directly in the loss function or in some other type of policy rule outside the loss function. And there's no standard method for identifying groups. And we also know that there are intersectional groups, people who have multiple health conditions, people who have intersectional identities. And so what we did in this paper was extend the concept of variable importance to group importance to create a new measure for groups defined by multiple attributes, so having multiple sensitive attributes. And this work was led by Anna Zink, who's currently a researcher at University of Chicago. She also led that biometrics paper that I mentioned 2 slides ago and was a collaborator on the multiple groups paper. And so what we found here in both Medicare and the health insurance marketplaces across 3 different years. So again, we were thinking about how robust these results would be across years and then across different health insurance sectors. We found many different previously unidentified undercompensated groups. And this undercompensation was quite large. So you can see here that the group that has asthma and heart disease and kidney disease, this very top row, was undercompensated by about $30,000. And so that's very high. When we think about, again, an average enrollee might cost around $6,000. And so there's there's a path here that tools of this nature could be a way for us to have more equitable healthcare. But again, solutions may lie outside the loss function. So it's not necessarily the case that every undercompensated group would need to be included in the loss function. And we could think about policy changes, which is something that has occurred in the past, and other avenues. Something else that I wanted to highlight was that in order to accelerate the translation into policy, we focused on writing other than academic papers. So these last three papers that I just mentioned, we collaborated with the Stanford University Human-Centered Artificial Intelligence Institute, Stanford High, to develop a policy brief summarizing all three of those papers for policymakers and to translate that work for a different audience in order to bring that work to a broader audience. Because you may have noticed the first paper was published in the Statistics Journal, the second paper was published in a Health Econ journal, and the third paper was published in a clinical journal. It's really unlikely that even most researchers would be reading all of those journals and find all those papers, but certainly not policymakers would be likely to find all of those papers. And in addition, we know that a biometrics paper is not necessarily written in a way that for a policymaker. And so this is a great opportunity to translate a work from a statistics journal to that new audience. The last set of studies that I want to talk about focuses on chronic kidney disease. And chronic kidney disease is highly prevalent. Around 10% of people in the world have chronic kidney disease. In the United States, where we conducted our study, 1 in 7 people have chronic kidney disease. And a main focus of care management in chronic kidney disease is preventing kidney failure. We also have in the United States many different health disparities within chronic kidney disease, particularly by race and ethnicity. And in the US, we have historically been using an equation that had a race variable in it to decide the care management for chronic kidney disease patients. So this is the EGFR formula. And we knew that including race adjustment in clinical formulas can propagate racial bias in decision making. And so what we wanted to do was study this formula, in particular in a prospective evaluation, because there was a recent high-profile national change in the United States to this EGFR equation to remove the race variable and adjust the formula. And so this work was also led by Marika Cusick in collaboration with Michelle Williams at Stanford Healthcare, Doug Owens, and Glenn Chertow. And we were trying to understand how CKD care might change 2 years after the implementation of the new formula that did not include race adjustment. At Stanford Healthcare here in California, this change happened in December of 2021. There are other health centers that had this change happen at slightly different times, and then it's not necessarily pervasive that this change happened everywhere. The work also involved simultaneous qualitative and quantitative work. And I will say this is an example where, as statisticians, the qualitative work was incredibly important in order to do a rigorous job for the quantitative analysis, in order to understand what we were seeing in the data at Stanford Healthcare. So this included us talking to a variety of different researchers, including folks who were involved in data quality. We talked to nephrologists, pathologists, primary care providers, and additional folks in order to understand a lot of different aspects of how this policy change happened, but also to understand what other types of exogenous shocks might be happening at the same time, to see how reliably we could isolate the changes that we might see or whatever results we might see, how much we could attribute that to the change in the formula versus other things that might have been going on. And so what we found in our results was that post-implementation, 2 years post-implementation, that there was no impact on nephrology visits or referrals. And this was an important finding to see that this hadn't changed. But we also made sure to be really clear in this paper that we did not study longer-term outcomes like transplantation or mortality. It could be the case that in order to see some of the benefits of a formula change, we would need to study it over a longer period of time. We also only studied this in a single medical center at Stanford Healthcare, and Stanford Healthcare is not representative of other regions in the United States. It's not representative of the United States as a whole. And so one of the things that we felt really strongly is that we wanted other people to do these analyses in other settings to see how robust this finding was in other large health centers, in primary care, and in other healthcare settings. And so this is an example of a piece of work that I would say we were very well aware that this was it was timely to understand the impact of this formula. But we also knew that we wanted to reach a clinical audience potentially with this work, that was an audience that it would potentially be most impactful for clinicians to read this work. And so we initially sent this to 2 different clinical journals, and both times the paper was desk rejected. And so I immediately saw that, okay, it doesn't seem clear that these journals are seeing the potential impact of the work. We're going to pivot. And we decided to send it to an interdisciplinary computer science conference where they peer review papers for their conferences. I know many of you also publish in both statistics journals and in computer science conferences. So we sent this work to Chill in February of 2024. It was accepted in April of 2024. The conference was in June, and then the proceedings came out in August. And so as far as focusing on balancing, we have this timely piece of work. We want to have it rigorously peer reviewed, but we also do want to be able to share it with the community because we do believe that we need to see more of these types of analyses, and it's helpful to see this finding that we found no change. We were excited about the opportunity to publish it with Chill, but then again, we also wanted to do a policy brief, is in particular in this case because we hadn't published it in a clinical journal. And Chill is an interdisciplinary conference with clinical and computational researchers involved. But it was a great opportunity to collaborate with Stanford High again on another policy brief for this paper, as well as my department, Stanford Health Policy, such that we could share this work. And these policy briefs are really widely read. And as a result of publishing this paper and releasing this policy brief, the work was featured as the first and only so far post-implementation evaluation of the new EGFR formula in the United States in this recent December news feature in Nature. And I wanted to highlight this for a couple of reasons, including that I was very appreciative of how much our findings were contextualized among a lot of different work in this article. I also thought it was really important that this feature focused on global perspectives and not just focusing on the US. And so much of the discussion around chronic kidney disease testing and the EGFR formula has been very US centric. And there are many incredible perspectives in this feature from researchers around the world discussing how kidney tests are working in other types of settings and how they work across the globe. I will also say that I was very pleased that all the caveats that when I spoke to Liam Drew, who wrote this paper, this feature, a lot of the caveats that I gave about, our work being only in a single medical center and we need to study longer term outcomes. A lot of that made it in there, which I appreciated as a statistician and somebody who really wants to make sure to accurately convey the meaning of our work. So when we talk about race adjustment, a lot of times it then comes up, well, what about social drivers of health? Should we be including those in algorithms instead of race adjustment or in addition to? And of course, there's lots of nuance about this topic of including social drivers of health. We recently wrote a paper about this that was published in JAMIA, again, led by Agata Foricharj, a CS PhD student here at Stanford, graduating this year. And briefly to summarize is that a key consideration with social drivers of health is that including them in predictive algorithms can help ameliorate the impact of these drivers, or it can actually serve to reinforce an inequitable equilibrium. And so deeply understanding the substantive problem that you're working on is crucial when you're developing an algorithm to understand whether this is something that would potentially improve health equity or cause harm. The last study that I wanted to mention is one of our years in the making studies of counterfactuals in primary care. I mentioned a number of studies that we conducted in large medical centers, but I did signpost that it's important for us to be evaluating in primary care, and I'm glad that I have the opportunity to do this in collaboration with a number of folks at the American Board of Family Medicine, as well as additional researchers here at Stanford, in leveraging unique data from primary care clinics across the United States. Primary care in general is understudied, and algorithms in hospitals, we know they may not transfer to the primary care setting. Primary care is also often one of the last areas in medicine to benefit from new technology, despite being the first point of continuous coordinated care for patients in the United States. And so we have a very large project bringing together causal inference, counterfactuals, decision science, and ameliorating bias in data coming out as a preprint in March that we'll be very excited to share with you. This is another project led by Agata Foricharge. So to close my talk, I wanted to end with the question of why, that we should be asking why a lot. Why does this algorithm exist? Should it exist? You know, we don't have to accept the status quo as an appropriate baseline. We should also ask, why am I doing this work? You know, who is doing the work matters. Why are you doing the work? And when we're thinking about building in additional rigor and robustness, when we're thinking about ethics in our work, being very honest with yourself about why you're doing the work is important. And it's something that I repeatedly ask myself, you know, am I uniquely positioned to do this work? And um, I'm glad that a lot of the work that I push forward falls into that category. And that's a great segue into the fact that I am really privileged to work with a team, learn from, and lead a team that has just an incredible set of perspectives and different backgrounds from statistics, engineering, epidemiology, computer science, decision science, and policy. And I also am recognizing most of the projects that I talked about today, or many of them are funded by my Pioneer Award from the NIH. And then I have some of the other funding sources from a couple other studies listed here as well. And with that, I will end my talk, and I look forward to the Q&A. Thank you very much.
That was fantastic, Sherri. Thank you so much. A very exciting presentation. It couldn't have been timed any better, frankly, at least for those of us here in the States. And we'll now be answering questions. So I'd like to hand the program over to Raphael. And at this point, if you have not had an opportunity to add questions to the Q&A section in Zoom, you may do so now, but Raphael, I'll hand it over to you.
Thank you very much. Thanks a million for a brilliant talk, Sherri. That was great. While people are still plugging in some questions in the Q&A, if that's okay, I'd like to start with some of my own questions because I thought that was very
Sure.
thought-provoking. And I don't work in public health myself, but I thought that was really interesting. So I guess my first question for you is like you started your talk mentioning about environmental impact, and as an environmental statistician myself, that was really interesting. And I was thinking, you definitely have heard of the new fashionable trend that we have in machine learning, which we now call green machine learning, which is quite interesting. And we've been looking at that in terms of fitting machine learning models using more energy efficient algorithms and so on. So I was just wondering, any perspectives that you might have of the use of green ML or green statistics in the public health area?
So I'll be happy to speak to that briefly. One of my goals in mentioning the environmental impact was specifically for us to be thinking about exactly this topic, including the example I gave is, you know, is this inordinate need for additional compute? Is this growing algorithms and models much larger? Is that necessary for the problem? And I think that it's important for us to consider the energy resources that we're using and and this is something that, we historically had done because we needed to. We didn't have either the hardware we needed, or then in recent years, cloud computing was very expensive, and it still can be. So I absolutely think that having constraints around the resources we're using to build these algorithms is very important. And then I would also say that relates to the issue of research waste that I brought up is, if we're just trying to publish as many papers as possible, build as many tools as possible, have our algorithms grow as large as possible, that is not necessarily serving the research outcome, and it's also not serving us from a resource consumption perspective as well.
Great. Thank you. We do have one question here in the Q&A from Max, and they're saying, thank you for this excellent presentation. Could you recommend a formal analytic process for evaluating bias in an algorithm?
Great question. So there's a few different frameworks you could consider, or analytic processes you could consider. One of the papers that you could start with was the one that I talked about, the ethical pipeline for AI and machine learning, that was led by Irene Chen, that I included a citation to. That's one example. There are some other citations in there, but it gives you an analytic framework for how to think about these problems.
Thank you. There's a question here from Penello, and they ask, can we evaluate fairness without looking at subgroups?
Great question. So when we think about the formal fairness literature, there's usually two buckets that people consider, group or subgroup fairness and individual fairness. So those would be the two main categories when we think about a lot of the metrics that are calculated. But if you think about fairness much more broadly, if you want to evaluate fairness of like what research questions are being evaluated, or again along that whole pipeline, there's a lot of different definitions of fairness that wouldn't necessarily be focused on subgroups.
Yeah, actually, as a follow-up, I'd like to ask, how do you think how challenging is it to actually get the definition of fairness in that area? Because I was thinking, as you were presenting, I was thinking to myself, how would I actually define that, and how would I calculate that myself? Do you have any perspectives to talk about?
Yeah, so how to define fairness has been a long discussed, long researched, long published topic. And I guess the short version is there is no single answer. For those of you who are familiar with algorithmic fairness, that is the answer you probably expected. But there are a number of one of the papers that I discussed that had that figure about data bias has a great summary of some of the different ways of defining fairness. But a key thing, again, that I would highlight is being really integrated in the applied problem. So when we think about how difficult it is to define what fairness means, is deeply understanding the substantive problem you're trying to solve is necessary in order to do that well. And even then, it's not necessarily like there's a single answer. And so you often, again, want to consider multiple metrics and think about how the interplay between them, and whether, there's a lot of different fairness results about how you cannot optimize, some of them you cannot optimize two at the same time. But incorporating what the ultimate either policy goal is or health outcome goal is really important. And again, those social structures that are built into the substantive problem.
Perfect. As a follow-up, I was just thinking as well, what are the current limitations of the actual statistical methods that we use to evaluate AI fairness, for instance? Because I would imagine, depending on the method, depending on the definition, there will be certain limitations there as well.
There are definitely some kind of statistical limitations when we're thinking about how to build fairness into different types of tools, especially tools that don't necessarily optimize the same way that we would for like a standard objective function or a loss function. I think there are different issues when, okay, we have multiple intersectional groups and now we're getting degenerate solutions. And so there are definitely a lot of interesting I don't want to call them edge cases, but just the
Mm.
more complex, realistic problems are the ones that have fewer solutions, fewer technical solutions. And so I think a lot of those are interesting, and some of them we're currently working on in my group. But I think additionally, building those constraints into more complex algorithms is something that is also an understudied space.
Mm. Thank you. There's another question here in the Q&A. They say, wonderful talk. Given HIPAA and other privacy requirements, would you have a sense how much actual clinical data are being used in large language model training? And it also seems like some existing tools such as Epic or Tabula have more access to clinical data, which could lead to an unfair monopoly. And could you comment on that as well?
Yeah, so I'm happy to try and answer this. So do I have a sense of how much actual clinical data is being used for LLM training? This is a great question because the lack of transparency makes it a little bit hard to answer. What I can say is that we do know that there are some health systems that are, for example, recording patient conversations without asking their permission.
Oh.
And so, and that they've decided that consent is not necessary to do that so that their LLMs can transcribe. And so what I would say is that we do not currently have a great sense of how much actual clinical data is being used because you may not even know that you're part of the training data. You may not know that your clinician recorded your visit and that they're using a transcription service that uses large language models to analyze that visit and help create a template for notes. And then the second part of the question, have access could lead to unfair monopoly. So I do think regulation is important here, and I think it'll be interesting to see how that progresses in many countries, including here for us who live in the US. But I do think that we should have significant concerns about who has access to the clinical data and, you know, and what types of clinical data, the consent related to it, whether this is, whether it's specifically a monopoly issue versus, this trove of data. You know, there's also concerns around security and privacy, which would be kind of a very near-term concern before necessarily we get into the issue of monopolies, particularly when we know that we have data breaches happening constantly.
Yeah. Um, I have another question, if that's okay. I'm quite thought-provoking. So, shifting a little bit more towards global health equity, Sherri, I was just thinking, would you recommend any sort of statistical framework that can help ensure that AI models that are trained, for instance, high-income countries, can generalize to low-income countries or middle-income countries, when especially there's not a lot of data coming from those countries?
This is where I would say it is absolutely a concern that we not assume that algorithms developed in one context would transport to another. And in particular, that when you talk about, high income countries to low income countries, we need to we need folks who are from those actual countries to be leading the conversation and leading the development of the tools that would be incorporated there or be involved in the transporting of those tools to that context, because absolutely, I mean, we don't even see tools that transfer between two large, well-resourced medical centers in the United States. That doesn't work. That alone doesn't work. And then we also know that, even in the same in the same well-resourced hospital across years, we have a degrading of the algorithm over time. So absolutely, and especially when we think about who has power over the algorithms and which large companies are building these tools, that we be very cognizant that this is not something of like bringing those tools to environments where they're going to both not work well. They already don't work well in a lot of the environments they're in now, and uh, not having the group that will be most impacted by the algorithm be empowered to reject it.
Perfect. Thank you. I suppose that would be a similar answer. Then I had a follow-up to that, which would be how would you handle incomplete or missing health data especially for marginalized groups and
Mhm.
within the same country. But then I suppose that would be a generalizable answer. Or would you like to comment on that?
Yeah, I mean, there isn't a generalizable answer, but this is another question. This is something that we've been doing for decades in statistics, right? Is thinking about missing data, and then also thinking about bringing our knowledge about subgroup analysis, and then bringing in, the knowledge about marginalized groups in the healthcare system. One of the answers is that in a lot of these cases, depending on how bad the missingness is that we just the analysis cannot be done reliably, and we need more folks who are willing to say that. And so depending on the context, so I can say just in a research environment, there's a lot of papers that just don't need to be published because the analysis is not going to be rigorous. When we're thinking about making policy decisions and it's like, okay, we need to have a solution to this answer. Absolutely, then we need to tailor our knowledge about missing data problems, subgroup analysis, and smaller group size in order to see what's the best job that we can do and centering fairness from the beginning.
Perfect. Thank you. I don't see any other questions in the Q&A, but if possible, could I ask you a general question? Because
Sure.
as throughout your presentation, we reached about 80 participants in close to 80 participants in the Zoom call, which is great. So I'd like to thank everybody who's joined us. Well, this evening for me, but this morning for others, and this afternoon. And but I'm sure that some of them are early career people, PhD students, or early career assistant professors. And I was just wondering, which piece of advice would you give to someone who's just starting their journey as an academic, maybe a first year PhD, and they're very passionate about using statistics to address inequities in health?
Ooh, so if I had to pick just one, my default is often live your values because it applies in so many scenarios. And in this particular talk, it's something that I actually talked about in the presentation. But it's something that you will keep coming back to when you think about the types of research questions you want to work on, including applications, and the type of statistics problems that you choose. What are you interested in? What problems do you want to solve? Focus on those things versus necessarily some of the chatter that gets over your head about what you should do, or like the best statisticians do this or the best statisticians do that. And when you try to sort of back calculate from that, a lot of us have been high achievers our whole lives. Many of us are also very type A. But living your values and just coming back to that is something that I think can help you from derailing. But also, I'll also say for early career folks, it's just really exciting to be a statistician. The continual learning, I think, is really exciting, and that's something that I've done throughout my career. And so I love being a statistician.
Absolutely. Well, that's great. Thank you very, very much, Sherri. Thank you. I'll pass it over to Peter.
Yeah, thank you so much. And it's great to hear your just excitement about the profession and where we are headed and what we can do to improve things even more. So thank you so much for being here. We'd be happy to answer any additional questions through the IBS members community. And all of you as members have complimentary access to this service just by logging in online. So any questions submitted using the Q&A feature that we neglected to cover, but I think we've covered them all, will be answered as quickly as possible. Otherwise, you can go online to the biometricsociety.org website and add your questions there, and happy to field them. A recording of this session will be made available next week under the Video Sessions tab in the Education section. You can find that in the main navigation of the website. And just remember that you have to be logged in to your member account to see all of that content. But thanks once again to all of you joining us, no matter what time zone you're in. I hope that we might see you at our next event, which is the February Journal Club. Enjoy the rest of your week, and you may now disconnect from this session. Thank you, Sherri, Raphael. Fantastic.
Thank you.
Thank you.
All right.
There's lots of virtual applause